Hello, this is Hiroshi and Mashimo, and thanks to the organizers for the invitation. Greetings from Boston. It's a great pleasure to be speaking with you, and sorry I'm unable to join you live today, but I'll make this available, the slide deck available for distribution. For This talk is really for patients to better understand their illness and self-advocate, and also for care providers to make more rational treatment choices based on the understanding of the underlying pathophysiology. The main take-homes I want to make are that besides diabetes, poor glucose control, medications, abdominal surgeries, uh, pregnancies, etc., may lead to disorders of gastric emptying, whether it's too fast or too slow, and lead to symptoms of gastric discomfort, nausea, vomiting, and bloating. And the measures of gastric emptying, whether the timing or the severity, really poorly correlate with GI symptoms and overlaps even with functional dyspepsia. The mainstay of medical therapy then is symptom-based and not based simply on improvement of some stomach emptying parameter. And these include promodalized anti-nausea, pain reduction, and addressing other coincident issues such as bacterial overgrowth or malnutrition and food aversion, and the underlying inflammation and anxiety, depression. And there are non-medical treatments that include herbs, potentially electrical stimulators, and GPOMs and tubes that we'll also touch upon. The importance of gastropathy and diabetes care cannot be overemphasized since doctors generally screen things such as kidney, eyes, and foot problems in diabetic patients, but forget to ask about uh, the GI issues, mainly because patients aren't volunteering that information or are not directly asked. And symptoms can be confused also with more common entities such as gastroesophageal reflux disorder or ulcers, gallstones, pancreas problems, or irritable bowel. And these can be manifest by poor oral glycemic control itself. So it's very important to review medications, which will go further. And important to realize that 19 to 76% of patients in diabetes clinic report significant GI symptoms, most commonly early satiety, reflux, abdominal pain, and nausea, vomiting, which are also suggestive of gastropathy. So what is gastroparesis? Well, gastroparesis is, by definition, delayed gastric emptying in the absence of a fixed mechanical obstruction of the pylorus or duodenum. But it's important to realize that this is really a spectrum of which overt paresis is in the extreme, and that there are many other pathophysiological problems such as dysrhythmia, hypomotility, dilation of the antrum, and poor fundic accommodation, which is in the spectrum. So we prefer to call this a gastropathy rather than a paretic stomach. And in diabetes, we have to consider potential other causes besides the autonomic neuropathy that's occurring. And these include metabolic and endocrine disorders, the important ones in orange, including DKA, diabetic ketoacidosis, for example, in type 1 diabetes, pregnancy, and hypothyroidism, the various medications that we'll talk about. And with the increase in such surgeries such as bariatric and anti-reflux surgeries, clearly vagal nerve injury should be considered if in the history. And yet, despite all that, a third are idiopathic, meaning we don't know why the stomach is behaving the way, not the way it should be. And so what are some of the emerging key concepts have to do with the stomach that is not a simple bag, but has different areas of different function, and that the solid foods are emptied differently from liquids. And secondly, that the relationship of the muscles and nerves are required to have a coordinated emptying, and then that there's inflammation and altered sensory nerve function that is leading to some of the enhance symptoms in these patients. But the understanding is important for rational treatments. So to begin with, the stomach, although there's no borders between these areas, can be uh, considered as proximal versus distal. Well, the proximal is responsible, particularly in the fundus, for kind of an accommodation or reservoir of the food, decontamination, and this part is really responsible for coordinating the liquid emptying or the rate of liquid emptying. On the other hand, at the very end of the stomach is the outlet resistance, or the pyloric sphincter, which will keep this small opening to sieve food and at the same time prevent reflux while coordinating its relaxation with the waves being done by the second or the distal part of the stomach that has to do with propelling the food down, churning it, crushing it, and then during that wave, bring some of the triturated or ground up food into the duodenum, while the rest are retropulsed back into the stomach for further grinding. And coordinating all this is a pacemaker, although not an isolated area as in the sinus node of the heart, but this is creating a wave that marches down at about 3 cycles per minute down the stomach distally. And what we find in diabetes particularly are various parts of dysfunction, including impaired relaxation, which leads to problems with accommodating food, decreased sphincter tone up here at the sphincter, lower esophageal sphincter, which you might imagine can increase some of the reflux symptoms, the dysrhythmia, which then does not coordinate the sweeping contraction wave, and this area here can be either dilated or have poor contraction waves or hypomodal. And this area here, the sphincter, can be either spastic or actually quite patent and not having much tone. So to begin, the liquid and stomach emptying is quite different. And this proximal area of the stomach creates a high pressure zone, which then is responsible for taking liquids down to the stomach to face this low pressure distally. So it doesn't take a weatherman to mention that this high pressure and the amount of tone that's created here will influence liquid emptying, which does not have a delay. As soon as you start drinking liquids, it will, in a linear fashion, start coming out of the stomach. In contrast, the solid emptying is driven by food content. That is, the solid, depending on its physical and chemical characteristics, has to keep getting churned up, crushed in this terminal antrum, and then retropulse, and this requires this coordination back and forth. And some of this is mediated by chemosensors of the kind where the small ground up food and these chemo and stress receptors along the small intestine mostly elaborate hormones that will help to delay the gastric emptying. For example, those with high fat content are driven by CCK then to say, hey, hold on, don't let go of that Mac burger with lots of protein and meat and grease. There is one hormone, however, ghrelin, which will help enhance the gastric emptying down. And these are all driven by these sensors along the lining of the duodenum, giving these hormones back. The other component of gastric emptying is really the understanding of a yin and yang relationship. And it was always thought that the essence is of contraction, that is, those that enhance gastric emptying driven by substance P and acetylcholine. But just as important, if not more important, in diabetic gastropathy was the loss of this inhibitory motor neurons, particularly those driven by VIP and nitric oxide. And this came to fore when I was involved with a mouse model, a genetic deletion of two sources, genetic sources of nitric oxide, the neuronal endothelial nitric oxide and the endothelial nitric oxide synthase. And it turns out that the deletion of the neuronal nitric oxide synthase led to this huge stomach. That, when you open this up, can sometimes be found a bezoar, which is not a Mikimoto pearl. It's actually a concretion of food that then creates a valve, kind of ball valve effect, and even prevents stomach emptying. Whereas that abnormality was not present in the endothelial nitric oxide synthase knockout gene, which looks pretty much like the control wild type mice. So this actually became the very first genetic model for a GI dysmotility, and this had to do, of course, the major neurotransmitter inhibitory in the stomach. And this we have shown leads to a delayed gastric emptying of both solids as well as liquids, which was not seen in the endothelial or other neuronal nitric oxide synthase source. But this is also seen in terms of the importance of the dysfunction in inhibitory or nitric oxide pathway in many other disorders, not just the diabetic gastropathy, but in achalasia, pyloric stenosis, even chronic constipation, and many others. Um, it's important clinically to note, though, that the severity of the dyspeptic symptoms do not correlate well with the extended delay in gastric emptying, either in type 1 diabetes nor in type 2 diabetes. And we can see that there are suggestive symptoms of potential pathogenesis in which we see, for example, early satiety, anorexia, and food avoidance may be indeed suggestive of defective accommodative reflex, and that some of the heartburn and epigastric pain may be more an issue of the sensory neuropathy compared to delayed gastric emptying that we classically see with, for example, nausea and postprandial vomiting. Does history help? Yes. The timing, one of the things important one to highlight here in the differential is that when it's before breakfast, particularly when the stomach should already be empty, think about hormonal problems such as pregnancy or uremia. Uh, and the duration can also help in terms of thinking about the differential diagnosis, since if it's hours to days and goes away, think about these acute infections or toxins and inflammation, whereas weeks to months can also be suggestive of obstruction or even psychogenic. And the type of vomitus that you see, if it's partially digested, also think about, obstructions in areas. If it's undigested, also even think about esophageal obstructions, such as achalasia. And if bile is present, think that the gastric outlet, that sphincter down at the bottom of the stomach, may also be quite patent open and not doing its function of preventing bile from getting into the stomach and then up into the esophagus. Feculent odor is usually of stasis, and that can be, of course, indicative of gastroparesis. Blood is always a red flag, so think about cancer and inflammation. And we talked about the amenorrhea of pregnancy, but headaches, think about brain tumors and previous surgeries. For evaluation, then, comes from, if you think about the definition that I started with, the delayed gastric emptying can be demonstrated by the gold standard of scintigraphy, but there are other ways to do that. And the absence of fixed mechanical obstruction distally can be done either by endoscopy or upper GI, small bowel follow through. In its evaluation, review medications, and that is very important. And to begin, the gastric emptying tests are made to explain the nausea or vomiting, to explain some of the motility like non-ulcer dyspepsias, uh, also to look at severe gastroesophageal reflux that may be refractory to medications. Suspected gastroparesis, such as in diabetics, which is the topic here. Suspected dumping, because sometimes dumping syndrome can mimic gastroparesis in symptoms, and chronic intestinal pseudoobstruction, etc. So what's done with these patients? The patient is put onto a table after giving a standardized, usually egg beater, which is impregnated with a scintillant, which can be seen radiographically with a counter. And this counter is placed over the stomach, and the outline after the meal is made of the stomach, and the stomach is traced in terms of how much scintillant is remaining there over time. In a normal person, you see that some of the stomach scintillant goes down. So generally, by 2 hours, you should have less than 50%. By 4 hours, less than 10% of the initial scintillant in the stomach. However, in the gastroparetic, you see that no matter how long you wait, even after 4 hours, there can be significant amount of scintillant in the stomach. There are other gastric emptying studying tests. The spirulina test, the GEBT, is the actually only FDA-approved breath test right now for gastroparesis. There are many others, largely experimental, and for example, the SPECT would require quite a setup and is not available in many centers other than research centers. But the smart pill is becoming also increasingly available. And the smart pill is actually a capsule, much like the video capsule, but in this case has a pH sensor, a pressure transducer, and a temperature thermometer. And what happens is upon ingestion, you could just imagine it reaches up to 37 degrees or body temperature, core temperature. And then what happens is when the pill gets in the stomach, it immediately drops to a low pH where the acid is. But when it gets out of the stomach into the duodenum and the rest of the small intestine, the pH climbs because of the bicarb secretion. And then when it falls into the cecum, there's bacteria there, and because of the bacteria, it reaches an acidity, and the pH just fluxes throughout the travel through the colon until the temperature suddenly drops when they poop it out, and that is then defining where the gastric emptying, small bowel transit, and colonic transit is. So with one pill, we can get not only stomach emptying, but the transit times through these. Mind you, these are transit times of an indigestible solid compared to scrambled eggs used in scintigraphy or the spirulina meal used in the breath test. Gastroduodenal manometry is not available except at specialized centers, but has a bunch of pressure transducers through a catheter that is introduced from the stomach, down the esophagus, through the stomach, and into the small intestine. And much like the esophageal manometry used for looking at dysphagia, this is looking at waves. And in general, what we can see is that in a normal, healthy person, we see good amplitudes and the coordination of some of these spike patterns with those transduced beyond the stomach into the intestine. The hallmark of musculopathy, muscle problems, is that these amplitudes drop and become weak, whereas neuropathy in general, such as in diabetes, we see not necessarily a decrease in contraction wave as much as discoordination. So again, discoordination in neuropathy, decreased muscle contraction, and musculopathy. Electrogastrography can be used with manometry, and the electrogastrography or EGG, the electrodes can be placed either mucosally or serosally. Serosally would mean usually by laparoscopy, surgically through an incision, whereas mucosally can be done endoscopically. Cutaneous is simply on the belly wall. That would be the simplest, of course, but would lose out on information in terms of how much is then coordinated with contraction, would basically be the muscle electrical activity alone. But this has been shown, for example, to improve with certain medications and improve with symptoms. For example, domperidone given to a symptomatic gastroparesis, and we see that before the treatment, there's very poor contraction waves, but after domperidone, we see this 3 cycle per minute waves getting restored. But the EGG interpretation can have frequency and power, may define abnormality in different subsets of patients. But interestingly, the positive predictive value of an abnormal EGG is estimated pretty well at 60 to 90%, and suggests that dysrhythmias themselves may be better indicators of symptoms such as nausea and early satiety and gastric emptying, and may better correlate with symptomatic responses to medication. Barostat is also not readily available in many centers, but this is a way of measuring gastric volume with a controlled bag pressure, and this will allow particular evaluation of the proximal stomach, the accommodative area, and look at pressure-volume relationships. So, what are some of the treatments? Well, the current treatment of gastroparesis or gastropathy is first to look at the underlying condition and, most importantly, to review medications. Today, with polypharmacy, clearly this is very important. And we also know that control of the hyperglycemia or even the vast undulation between hypoglycemia and hyperglycemia, that is, the glucose control itself improved can improve some of the symptoms. And this may require perhaps switching to insulin compared to oral agents. There are certainly hydration, nutrition concerns for those that are more severe, and dietary changes should be done with small, frequent meals with low residue and low fat, and consideration of psychological measurements, etc. Well, let's go on then to the review of medications. There are many, many medications that slow down gastric emptying. You'll have this in your slide set. But more importantly to consider for diabetes is that some of the diabetes medicines themselves, and in particular amylin analogs and GLP-1 agonists, can worsen gastroparesis by the fact that they can also decrease or slow down gastric emptying. And this may need a switch to the GGP, DPP-4 inhibitors, for example. We do know that some of the GLP-1 agonists, for example, exenatide has been studied and found to have far greater possibility of nausea and vomiting compared to sitagliptin. Um, and this is an important point to be made for care providers. For those that are more severe and even hospitalized, rehydration is the mainstay, and I've popularized this in a three-step program in various review articles that I've written. But so this begins not necessarily like a progression of a surgical patient, but for diabetes in general, we want to stay with sips of, say, Gatorade or salty bouillon with some vitamin replenishment and avoid things that are irritative, such as citrus or highly sweetened drinks. And then advancing to soups that may have mild carbohydrate sources, such as noodles, rice crackers, uh, and um, and in small volumes, but again, avoiding fatty food. And then step three, by introduction of more solid foods, yet avoid things such as red meat and fresh vegetables and things that are fibrous that are poorly handled in terms of emptying in the stomach. The pharmacological treatments are then not just to hasten stomach emptying, what we call prokinetics, but dealing by symptoms, so that if they have a lot of nausea and vomiting, then to deal with the antiemetics, the pain controls, and perhaps even the bacterial overgrowth. The prokinetics can be classified into dopaminergics, the motilin receptor agonists, the serotonergic agonists, and the muscarinics. And now that we see an explosion of serotonergics being introduced, simplistically, I should mention that the 5-HT4 receptor agonists are the ones that are promotolides, whereas the 5-HT3 receptor antagonists are the ones that would decrease or antagonize the pain or discomfort. So that's a quickie on the serotonergics. Um, some of the dopaminergic ones also have other activities, including serotonergics like metoclopramide and domperidone. I should mention, though, that in the United States, metoclopramide is the only medication presently FDA indicated for gastroparesis. So anything else I have to say, including even the popularized erythromycin, are all off-label use. Erythromycin is actually the strongest prokinetic known, but we do know because of its propensity to give nausea and even vomiting that by using lower doses we can decrease the side effects. Caution, of course, that there is some sudden death involved, perhaps because of its potential cardiotoxicity, and that erythromycin quickly tachyphylaxis, that is, that you need more to get more effect or not get effect at all within days. And so the actual use may require pulsing, giving a little holiday, drug holiday, and then reusing. Azithromycin or bioxins have been touted to have less of a side effect, and yes, it turns out that the actual byproduct is that actually hits the motilin receptor. One of the breakdown products actually requires acid, so caution there. If you really want the promotilide effect, you have to abstain from PPIs. Tegastride is back, although cisapride was pulled back and can only be used by compassionate use. But tegastride is back, used for constipation and lower GI symptoms. So again, off-label use. And prucalopride is also not studied yet specifically for gastroparesis, but this is a highly selective agonist, so it avoids some of the cardiotoxicity concerns of prior serotonergic agents. Bethanechol, a shout out that, although it's been used quite a bit, does have significant adverse effects, um, and, um, uh, and actually it doesn't hasten, but actually decreases or slows stomach emptying because the contractions become not coordinated. So when it is used, it's often used with another prokinetic. The antiemetics are largely dopaminergic. Again, metoclopramide, albeit prokinetic, is also a great antiemetic, as well as domperidone. Metoclopramide is now available even nasally, although before, if they're really vomiting, they'd be given PR or um, other means, even IV. And there are other dopaminergics that don't have prokinetics but are used, for example, in chemotherapy, nausea, vomiting. The 5-HT3 then are the newer ones on the block. Ondansetron, which is Zofran, is probably one of the more commonly used ones. And TCA or tricyclics, remember, used in lower doses, such as the equivalent of less than 100 of amitriptyline, will avoid then the anticholinergic effects. And we do see here cannabinoids are, of course, being popularized with antiemetic properties, although if you're using it every day for quite a while, even continuously, you have to start thinking about hyperemesis of cannabis, which, of course, has a hallmark of getting better with hot showers. For pain control, again, low dose of TCA is one of those that are popularized, but these can often come from an autonomic neuropathy. And while indomethacin and ketorolac can also be used to solve some of the, resolve some of the abnormalities in diabetes, also there's a caution, of course, that these themselves, particularly in diabetes, can cause ulcers and renal dysfunction. SSRIs are often used also, paroxetine and duloxetine, and it may be a double-edged sword if they're having some depressive features. But very importantly, do avoid narcotics if at all possible. The upcoming newer drugs potential for gastropathy would be the serotonergic agents, which have yet to be studied. The dopaminergics, TAK 906 from Takeda has recently finished its studies, and we're awaiting those in publication. And the cholecystokinin antagonists and the motilin receptors, opioids, again, these will be in your slide deck. The motilin receptor modifier, methylnaltrexone, has been a little bit of a disappointment, but is still touted for perhaps opioid-induced gastropathy, but not perhaps all gastropathies in general. Relomorelin did finish, or the study was terminated, not because of lack of effect, but because of company policy. There'll be others upcoming. Potential non-drug therapies would include ginger, acupuncture, and in this P6 Niguan point is actually what's being used for this relief band, which looks like a band that is worn at the wrist. And then you'll hear more about electrical pacing and stimulation from another speaker. Refractory patients would require prokinetic and antiemetic agent switching or combining, and in very severe cases, although very uncommon, uh, uh, people would advocate gastrostomy or jejunostomy. Botox is falling out of favor, and albeit that it's probably a matter of correct patient selection, it's presently not advocated unless part of a clinical trial. And gastric palms, that is gastric per oral endoscopic pyloromyotomy, much like the myotomies that's done for achalasia, could be done if there is an increased resistance outlet, and then planting potential electric stimulator or pacer. So if you look back at the physiology, then we can understand that the impaired relaxation, we can see agents that will help with that, including buspirone, despite its central nervous effects of dizziness, etc. So sometimes not very well tolerated, tricyclics, etc. If there's dysrhythmia, then we do know that certain serotonergics can help restore some of the rhythm there. And then this contraction issue, modalized would help here, including erythromycin or the motilin receptors. If this is quite hypertonic, then certainly ways to relax it, such as Botox or cutting through the muscle here with G-palm, may be the issue. And of course, if this is relaxed, proton pump inhibitors. You'll hear more about the stimulation system, the GEMS, from another speaker, but clearly this may have a role in severe gastroparetics. So basically, in summary, gastroparesis is commonly under recognized by care providers, and patients need to self-advocate, and clearly improved glycemic control can help. This is standardly diagnosed by scintigraphy, although the SMART pill and the spirulina breath tests have become more popularized, and of course, endoscopy or imaging study to make sure that there's no obstruction distally. And of course, review the culprit medications, and for diabetics, particularly the amylin analogs and GLP-1, correct underlying metabolic disorders, and treatment mainstay is symptom-based, uh, that is prokinetics, antiemetics, and pain control. With that, I'll quit. Thank you very much for your attention.